last speaker. So our final speaker today is Dr. Riccardo Pofi, who is a clinical research fellow in endocrinology at the University of Oxford. His work focuses on adrenal disorders with a particular interest in male health, so including CAH, adrenal insufficiency, and also the impact of exogenous glucocorticoids on the reproductive and cardiovascular system. And Dr. Pofi completed his specialist training in endocrinology and metabolic diseases at Sapienza University of Rome, where he also earned a PhD in experimental medicine in collaboration with Oxford. And he's currently leading projects aimed at dissecting metabolic pathways of glucocorticoids and understanding how they contribute to the individual variability in treatment outcomes. And today he'll present a clinical case on the management of CAH in males. So the floor is yours.
Thank you. Thank you very much indeed for the kind presentation. And good evening, everyone. And thank you very much for the invitation. It's a real honor for me to be here, especially after these two excellent talks we've just heard from real leaders of this field. My aim today is to take you step by step through this patient journey, showing how we try to balance disease control, metabolic health, and fertility, trying to reflect some of the real challenges we face in clinic. So let me introduce the case. This is an 18-year-old man with classic salt-wasting form of CAH, which was diagnosed at birth with salt-wasting crisis, and he's been on hydrocortisone and fludrocortisone ever since. His family history is relevant, as his sister is also affected, and through childhood and adolescence, things have been going quite smoothly. He had normal development, normal puberty, and remained clinically stable on his treatment. But just a month before I saw him in clinic, he had his first testicular ultrasound, which showed bilateral testicular adrenal rest tumors, quite sizable already. And at that time, a semen analysis was requested, but he preferred not to undergo it. So we still didn't have any information about his fertility at that time. And when he first came to see me, he mentioned he had just moved in town from university to study in the university. And he told me he thought it would be better to continue his follow-up with us rather than back home, which all makes sense to me. And we agreed to schedule a hospital appointment to make sure that we carry out a thorough baseline assessment for his health. At this point, he was on a standard dose, standard regimen hydrocortisone, immediate release hydrocortisone 3 times daily, 10 milligrams in the morning, 7.5 in the afternoon, and 10 milligrams at bedtime, together with fludrocortisone twice daily. And looking at his anthropometrics, his weight was 75 kilos, with height which was 165, which, as you can see, is shorter than expected from his parental target height, and giving him a BMI of 27.5, so overweight. And his metabolic profile was normal. And regarding disease monitoring, we could see that the patient was overtreated with both 17-OHP and ACTH being at the lower end of the reference range and androstenedione suppressed, while testosterone and gonadotropin were normal. And if you look at the androstenedione to testosterone ratio, this was very low, and therefore confirming that the patient was overtreated. Normal electrolytes and renin were so no issues here for the mineral-corticoid balance. And regarding cortisol levels, these were close to the high reference range, but we decided to better look at this and his cortisol day rhythm by performing a cortisol day curve, which is shown here in red. And as you can see, there was a misalignment compared to the physiological rhythm, with high peak in the morning, and then these just straight after the morning dose of hydrocortisone, and then a deep trough in the afternoon, and then a rebound again in the evening following the afternoon dose. Moreover, when I specifically asked him about adherence, he admitted that since starting university, it had become difficult to stick to the 3 times daily schedule, and he started to miss some of the 4 p.m. doses. So to summarize this first assessment on conventional 3 times daily hydrocortisone regimen, his cortisol profile showed peaks and trough, therefore under and over exposure during the day. He also sometimes struggled with adherence to the afternoon dose. despite biochemistry pointed towards overtreatment. And we saw that his BMI, importantly, was in the overweight range. So at this point, our goals were threefold: improve adherence, bring him closer to a physiological cortisol rhythm, and avoid excess of glucocorticoids exposure. And therefore, at that time, we didn't have the modified release hydrocortisone available, and therefore we decided to switch him to dual release hydrocortisone, so the Plenodon, 20 milligrams in the morning, and then reduce his hydrocortisone bedtime dose to 7.5 milligrams. And 6 months later, when he was on this therapy, he mentioned he found this regimen much easier to follow, which was a first step forward, of course. And if you look at the anthropometrics, he managed to lose some weight, 2 kilos, not a huge change, but still encouraging, given the history of overweight, while his metabolic profile stayed unchanged. And in terms of disease monitoring, we saw slightly improved disease control overall. ACTH was a bit increased from the previous assessment, while 17-OHP reached the values slightly above the reference range. Androstenedione, on the other hand, sat on the lower side of the normal range, which with normal levels of testosterone gave a AT ratio moving closer to the 0.5 cutoff, still on the overtreated side, but suggesting a better balance between adrenal and testicular androgen production. Gonadotrophin normal, electrolytes normal. So again, no issues here. And when we repeated cortisol day cube, this looks closer to the physiological one, albeit not yet fully aligned. This time we decided to repeat the testicular ultrasound, which showed small testicular volumes, heterogeneous, and we confirmed the presence of TARDs, which showed all the classic US feature. So bilateral lesions, hypoechoic, heterogeneous, with this modular pattern, vascularized, and located in the mediastinum. So good news that the lesions were essentially unchanged from the previous scan. But now, after confirming this presence of these TARDs, the next important step for us was to explore the impact of TARDs on fertility. And as I mentioned before, the patients refused to undergo 2 semen analysis before, but now engaging him and establishing a good relationship with him, we explained how crucial it is for us to assess fertility, and therefore he finally agreed to proceed to do semen analysis, which, as you can see here, showed overall acceptable spermatogenesis with normal semen volume, concentration, morphology, and aside of slightly reduced progressive motility, overall showed normal spermatogenesis. So again, to just sum up the 6 months assessment, while on dual release hydrocortisone plus 7.5 of standard hydrocortisone at bedtime, his adherence and cortisol rhythm slightly improved. Biochemically, disease control was slightly better, still a bit overtreated. Weight has dropped slightly, and TARDs were stable with normal spermatogenesis. So our plan was then to continue and optimize therapy further to titrate down the hydrocortisone to get closer to the suggested recommended total daily dosing. So we decided to reduce further the bedtime dose of hydrocortisone to 5 milligrams and see him again in 6 months. However, when he came back at 12 months, when I asked him how things were going, he mentioned that he started to feel more tired, university was getting harder, and when I specifically asked about his therapy, he honestly told me that he kept forgetting the bedtime dose. But what I found really interesting was that he clearly mentioned that when he was at home with parents, he was obviously following the schedule, the treatment schedule was easier, but now he's alone at university. And this is something we often see in clinic when young adults in transition, often struggling with adherence where parental support is gone. And already from the conversation, I was suspecting that this could be the reason behind the symptoms he was reporting. We went ahead with bloods, and in fact, by looking at this disease monitoring, it was clear that the control had really deteriorated with ACTH, which was raised, 17-OHP and androsten iron to the roof. The A40 ratio had risen well above 3, clearly indicating that a large proportion of androgens now are coming from adrenal origins and therefore confirming overtreatment. And if you look at the gonadotrophin here, albeit still in the normal range, LH was on a lower side, again suggesting that testicular function here was being put under pressure. So at this stage, we decided to repeat the testicular ultrasound and semen analysis to check whether this has impacted on fertility. And in fact, as you can see, when we did the ultrasound, this showed increase in TARS volume and also parallel increase in vascularization, suggesting activity and progression of these lesions. And at the same time, the semen analysis was worsened, so reduced concentration volume, just slightly better than the lower reference range. Sperm count, total sperm count reduced, motility even worsened, albeit morphology stayed in the normal range. So at this stage, we faced with poor disease control, consequence on TARS, progression, and fertility. And since the patient was not seeking fatherhood at that time, we felt it was extremely important to not to miss the opportunity, and therefore we proposed him a sperm cryopreservation, which he accepted, and then we proceeded freezing his sample to secure his future reproductive options. So at this stage, 12 months later, after the first assessment, we had several key issues here. Poor adherence remained a problem, as the patients frequently forgot the bedtime dose. I did not mention for brevity, but weight was increased, and showing also, the blood showed also an increase in insulin resistance marker, HOMA index was increased. His BMI is now approaching the 28. Disease is not controlled, and this was reflected clinically by increased TARS volume and functionally by severely impaired spermatogenesis. So, as I mentioned, we cryopreserved his sperm, but we also decided to switch him his bedtime dose from hydrocortisone to a low dose of dexamethasone, 250 micrograms, aiming to better suppress ACTH and control androgens production. Of course, at the same time, I was really clear with him, your weight is going up. So DEX can be really effective biochemically, but that is carrying severe risk on your metabolic health. So please do exercise and diet. And see what happens 6 months later. He came back and the first good news was that he was finally taking all the medication, and the tiredness was gone. But he honestly, again, admitted that he didn't really take care of his diet, didn't exercise, and as you can see, he gained weight. So I reassured him this was not entirely his fault, and I told him that we will manage this together. And when we checked the bloods, as you can see here, it's clearly obvious how dexamethasone can suppress ACTH, 17-OHP, androstenedione, all markedly low, with a very low A-to-T ratio, indicating, again, overtreatment, while testosterone stayed in the normal level. However, this tight disease control came at cost. So his weight had increased now by 4.5 kilos. He's approaching obese threshold of BMI, and metabolic profile worsened quite badly with the HOMA index increasing. So on one hand, we had achieved disease control. On the other hand, overtreatment was really impacting his metabolic health. So at this point, I decided to go beyond bloods and ask again for ultrasound of testis and semen analysis, which showed slight decrease in TARS volume, but also changing in ecostructure of TARS. As you can see here, less hypoechoic, less vascularized, meaning that these were responding to the treatment. And in fact, functionally, we were lucky to see that the semen analysis improved quite a lot. And that was a good opportunity to us to request another cryopreservation to improve the quality of the straw we previously collected with the previous cryopreservation. So to summarize this assessment, again, adherence improved and disease control was better, but biochemically profile actually pointed towards overtreatment. On the positive side, TARS had reduced in size, semen quality had normalized, and this gave us the opportunity to cryopreserve again. But on the other hand, the main drawback was the weight gain and worsening of metabolic profile, which is a reminder of the constant trade-off we face in CAH management. So tighter biochemical control often comes at the cost of metabolic complication. With this in mind, we plan to halve the dexamethasone dose, try and improve his metabolic health, and of course, we further stress the importance of lifestyle as a key part of long-term disease control. And in fact, 6 months later, things looks overall better. He had lost about 4 kilos, bringing his BMI back to 27.9. From a disease control perspective, results were still consistent with overtreatment, though slightly improving. So ACTH in the low normal range, 17 HP and androstenedione both at the lower end of normal, with the ratio now moving towards the 0.5 threshold. Gonadotrophin, and I think this is important to see how the hypothalamus gonadal axis is recovering with FSH going up and LH back to normal levels. And when we looked at testis ultrasound, we had slightly increase in TART size and vasculature, which is not unexpected considering we are reducing the dexamethasone, but semen analysis overall stayed essentially stable. So at this time we had modified release hydrocortisone available, and therefore we decided, considering the picture was clearly stable, we decided to switch the dual release hydrocortisone to modified release cortisone and 10 milligrams at night and 5 milligrams in the morning, and to stop dexamethasone, just to try and aiming to a more physiological and metabolically safer regimen. And here is the picture 4 weeks later at the last assessment, which showed completely normal metabolic profile, which is of course reassuring. On the disease control side, ACTH has started to rise, 17 HP is elevated, but is still 3 times higher the upper limit of normal, with androstenedione completely normal. And we can discuss how the things goes with the modified release hydrocortisone. Testosterone normal, AT ratio now again even closer to the 0.5, even suggesting more adrenal surge of androgens, but still almost normal, and normal gonadotropin. So that said, we still don't have the full picture yet, but we're still waiting for the ultrasound and semen and perhaps the cortisol day reading we're going to perform next time we will see him. So to wrap up my case today, of course, this is just one patient, and we should always remember that CAH patient differs one to another. Difference in phenotype, genotype, lifestyle, adherence, all, and even the individual sensitivity to glucocorticoids can all shape outcomes. But I think this case clearly showed how we struggle with glucocorticoid replacement, which is always a fine-tuning and a compromise most of the time between over-treatment and under-treatment. How treatment choice really matter, because we know that immediate release hydrocortisone is probably the most used, but this has poor rhythm coverage and adherence challenges. Intermediate acting and the newer dual modified release acting, the formulation are likely to mimic the physiological rhythm and improved biochemical control. We show how even low dose of dexamethasone are really effective sometimes to suppress the CTH and androgen production, but of course you need to be aware of metabolic risk. Even that we show that fertility is highly dynamic and fragile in patients with CAH, because start size and semen quality, yes, fluctuate with disease control and treatment regimen, but not only with this. And we still don't know why they, how they can arise. We know when, but we still don't know what is going on there to make them grow so quickly, and how we can manage these. And for sure, here the sperm cryopreservation is essential to preserve reproductive potential, and of course, integrated longitudinal monitoring cannot be overstated. So anthropometrics, metabolic hormones all together gives us the real picture of how disease treatment and lifestyle can interact. So if I had to summarize my case in one sentence, this case reminds us that CAH management is a balancing act where compliance, treatment formulation, comprehensive monitoring come together to protect not just the metabolic and reproductive health, but the whole patients of it. And I will close by thanking you all, and a special very thanks goes to my two mentors, which is Jeremy Tomlinson in Oxford and Andrea Sidori in Rome. And I had the pleasure to working alongside with them, learning from their approach, both in clinic and research. And I'm happy to take any question.
Thank you so much, Riccardo, for that great example, and it sounds very familiar to me, and I think to maybe some of our other people there in the audience. So I think at the moment all questions are actually answered. Maybe because you talked a lot about TART, could you give an advice on when to start screening? We've also talked about transition earlier. So when would you suggest to start screening for patients, for TARTs and patients with male patients with CAH?
So as soon as you can. Puberty is a good time because we know that that is the time. So peri-puberty is the time when the TARTs can arise. Of course, disease control makes the difference. Patients with classic salt wasting, so the genotype makes the difference, because we know that almost more than 50% of patients with the severe genotype can have TART and then fertility issues. The problem here is always that these patients specifically, he refused to have a ultrasound scan when he was 15, and the colleague that sent the patients to us, then they performed a MRI scan without finding any TARTs. And when I first saw him, he was 18. So in that time, he developed the TART. So it's just one case, but I think peri-puberty is the right time.
Thank you. Yeah, that's also compliance questions is always a problem, I think, in treatment of patients. So maybe one more question, or actually now something came up in the Q&A box. No. Then maybe one more from my side. Would you suggest to start those patients on modified release hydrocortisone, or before you start using dexamethasone? Or do you have any other treatment options that you'd be thinking of in a case like that?
So modified release hydrocortisone just came out. So we really do not have enough evidences to check, to see whether this can improve fertility as at least as much as dexamethasone. What I saw with my cases with TARTs, dexamethasone is definitely very helpful sometimes, unless you don't have that kind of TART tissue which is not responsive to anything. So probably when you get to the stage when fibrosis reason to the TARTs, by that time, you can't really do much, even if you overfeed the patients with treatment. But I'm still waiting. So the data we've got with the modified release hydrocortisone just come from the extension trial and the first trials, which showed, not systematically, but clearly showed that some fertility outcome improved. So one patient had improved spermatogenesis, many female got pregnant, but fertility itself hasn't systematically been studied yet. I've seen some abstract around circulating, and it looks like some data on spermatogenesis are improving, but of course, it depends on which phenotype of patients you're selecting on your study.
Yes, thank you so much for the answers. Alberto, do you have any other questions or?
No, there are no other questions from the audience. No. So in case there's no fertility or issue anymore, and the biochemical control is very good, that will be a minority or subset of the patients. Can you decrease the periodical screening for TART, or what would you advise?
Sure. That's a really good point, actually, Alberto. So, yes, once you settle down all the fertility issues, you can clearly relax with TARTs. They are benign lesions, so you won't think about these TARTs being malignant. So you can start doing yearly assessment. Once you see that they are quite stable, you don't need to ultrasound them every 3 months time.
And there are no other longer term effects of growing TART with respect to testosterone production?
So yes, of course, once the TART has occupied all the testes, it's a problem for fertility. But yes, of course, you are pushing all the rest of the parenchyma, so testicular production might be affected. But the production of all the other androgens makes the things easier for the male, of course. Symptoms, I mean.
Okay, thank you very much. So, my dear co-chair, may I ask you to conclude the session, please?
Of course. So first of all, I'd like to thank you all for joining this webinar. I think we've had a great amount of visitors, actually. And of course, I'd also like to thank our excellent speakers for their great presentations. I think we've learned a lot. We'd also like to thank, of course, the European Society of Endocrinology, ENDO-ERN, and ESPE for organizing this very informative session. And also many thanks to our sponsors, Recordati Rare Diseases, for the sponsorship of this webinar, and as also the ESE Educational Calendar 2025. And on the slide, you can see a few more events coming up this year. So if you want, you can still register for those. And then also thank you to Crinetics, Pharmaceuticals, and Neurocrine for their sponsorship. And just two more reminders. So first of all, the webinar, as we already told you, was recorded. So this will be available soon on the ESE website. And you can, just a quick reminder as well, you can still take part in the State of Endocrinology survey. There's a QR code on the slide where you can find it. And I think this is a great update, or let's say fitness test of the field, where you can see how well endocrinology is prepared for the future. So I'd like you to all engage in that if possible. So thank you all for joining the webinar, and hopefully see you again soon.